Good morning, everybody. This is Dr. Nick Tulo with my Saturday morning live stream coming from New Jersey. It's another sunny Saturday morning in Jersey, but it's kind of chilly out. So I got my long sleeve shirt on, and guess what? Look at the new do. Hey, I bet you guys didn't recognize me. I should have talked like this, because then you would have thought I was my brother Louis. You know what I'm talking about? Hey, so yeah, I decided to go get away from the hippie look, and kind of everybody tells me it looks younger and hipper, and like, hey, I'm ready. So anyway, it was a busy couple of weeks. I was on call last weekend, so that's why we didn't do one last Saturday. Hey, Brian Gomez, thanks a lot. Jolly, I'm glad you were able to tune in. I work with Jolly. She's on the A team in the cath lab. One of my favorite people. So Mohammed, thank you for joining me. See, I'm getting better at looking at the comments, aren't I? You know, this is just practice. But you know, some of these YouTubers, they go on, they play games, they just kind of like pull out their iPhone and say, hey, I'm live, so let's talk about whatever, you know, and it seems so spontaneous. But I've been up since like 7 o'clock this morning. Yeah. Well, I had to take my daughter to take the ACTs, and then, you know, it takes me like an hour and a half to set things up. But this is going to be a really kind of interesting discussion. You won't find this anyplace else, because I mean, there's a lot of ECG stuff out there on YouTube, but pacemakers, I mean, you really have to know an EP to sit and look at a pacemaker strip and be able to have them explain it to you. So pacemakers are complicated, and as I said, sometimes they're weird. They work funny. They're kind of crazy. But I'm going to bring back something that I haven't used in like 20 years. Actually, back in the day, before I got busy with kids and live streaming and videos in my practice, I was very heavily into doing computer animation. I tried my luck at 3D animation, but I did a lot of 2D stuff, mostly using After Effects. So we're going to bring up an animated pacemaker thing. It's going to be fun. So anyway, thanks, Mohammed. I'm glad you find it to be good every time. So I'm going to keep them coming. And as I said, just try to subscribe to this channel, ECG Doc. There's a button down below so that you'll get notifications when I'm about to go live. And if you really like this content, tell your friends, let everybody know that I'm doing this. And, you know, as an electrophysiologist, I do bring a unique perspective on ECGs, and that's what these are all about. Anybody who wants to sort of go back to the basics or learn really advanced ideas and topics and learn how my brain works, you can check out ecgacademy.com. That's where my formal online course is. So let's talk about this case. It's actually a 60-year-old guy who had hypertension long-standing and some paroxysmal atrial fibrillation, and was diagnosed with tachybrady syndrome. I guess because he had some sinus node dysfunction, so he got a dual chamber pacemaker. And he came into the hospital for some unknown reason, he for pre-op or whatever, and I came across this cardiogram while I was reading ECGs. Oh boy, you know, this week I had to read like 3 days, and one day I had 190 cardiograms to go through. Oh man, it took me at least 20 minutes. Just kidding. But so here's the cardiogram. Let me share it with you, and let's see what we have. Aha! All right, so there it is. I guess you can see that on my screen, on your screen, I should say. Jamshid Bahir, thanks. I'm glad it's looking great. Kiwu, good morning to you too. So let's kind of go over this step by step. So remember, I always tell people when you're first starting looking at ECGs, always look at the whole forest. Don't concentrate on the first beat or two, because you'll get distracted. Just trying to get a sense of like what's happening. And you know, overall it kind of looks regular. There's maybe a little premature beat right there, but suddenly things change and you have all these crazy spiky things going on. So it's obvious that the pacemaker is working, but is it working correctly? And that's what you have to try to figure out. Why did it suddenly start pacing at this point? And look, even the QRS kind of changed. So, over here, there's no pacing. And then suddenly it starts pacing. So is this like, was it failing to sense? Is it operating correctly? When you look at a pacing tracing, you have to think about whether things look like they're working properly. Just because it looks weird doesn't mean that there's anything wrong. Pacemakers, for the most part, are 99 and 44/100% reliable. And they work properly, but they're so complex that you can program them different ways and they'll look like they're doing something weird, and especially with some of the newer features. Good morning, Pranapa. Where are you guys logging in from? See, I try to do it early Saturday morning on the East Coast, so that people on the other side of the world will actually be awake and be able to participate with this. So anyway, yeah, there are so many crazy features that can be programmed on and off with pacemakers, so it's kind of hard to figure out if it's working properly or not. And one of the most common things one of the things that we've learned over the last decade or so is that if you pace at the RV apex, if you have a lead at the apex and you pace all the time, it disturbs the normal sequence of the left ventricular activation. It creates almost like a left bundle branch block because the right ventricle depolarizes quickly and the left ventricle has to depolarize very slowly through intramyocardial pathways. So the QRS is very wide. And if you look at the wall motion, you'll see that the septum contracts before the lateral wall because the septum is getting the signal early from the RV lead, but the lateral wall is contracting late because the signal has to propagate over there. Now, if you look at an echocardiogram, you'll often read the paroxysmal septal motion or paradoxical septal motion, And that's very commonly seen when someone is paced. So and in some patients, especially if you start out with some left ventricular dysfunction, right ventricular apical pacing is not good. I mean, some people will go on to develop left ventricular dysfunction and even heart failure. So we've learned over the last decade or longer to minimize ventricular pacing as much as you possibly can. And so every pacemaker is programmed appropriately to try to keep ventricular pacing at a minimum. Unless the patient obviously has complete heart block, then you have to pace the ventricle. In that case, Kel, thanks from Sweden, right? Thanks for joining us. I always put my pacemakers on the septum, and I find that the risk of developing left ventricular dysfunction is really very, very low in my series of patients, which are many hundreds. But anyway, so pacing from the RV apex is not good. But that's kind of not what we're talking about. We're going to try to figure out what's going on with this pacemaker and whether things are working right. But see, understanding pacemaker timing functions, pacemaker timing cycles, gets a little hairy. Well, single chamber is easy, right? Pacemaker is basically a clock. And let's say if a single chamber pacemaker is programmed for a rate of 60 beats per minute, that clock is basically set for 1 second, right? Because it takes 60 seconds to get to a minute. With a single chamber pacemaker, every time the clock expires, every time that second runs out, the pacemaker sends out an impulse to the ventricle. And then the next timing cycle starts, and when the clock runs out, it paces again. So if you measure from spike to spike, you'll measure exactly 1 second or 60 beats per minute. The thing is that the pacemakers have to be able to accommodate for intrinsic beats, and so they have a sensing circuit. So if a signal is sensed at the tip of the lead, so there's going to be an electrical signal at the tip of the lead from the ventricular depolarization. So that electrical signal now gets sensed by the sensing circuits and inhibits pacing and resets the clock. That's all there is to it. So if the clock runs out, it paces. If the clock is interrupted by an intrinsic beat, pacing is inhibited and the clock starts again. So I've shown you how you can measure back from a spike to figure out when the clock started. You know, lots of tricks. I cover this in my advanced course on ECG Academy. I think single chamber pacing is, you know, pretty simple. Pair of calipers, you're good to go. Dual chamber pacing is a little bit more difficult. Now I'm going to show you this animation that I created. Now this was so long ago that it has my old practice, Arrhythmia Consultants of New Jersey. We were at St. Joe's in Patterson, and I was director VP there for 12 years. And I created this using After Effects, and it's really cool. But like if I run it, you're going to see how complicated this is. Okay, so that's kind of like what a pacemaker, a dual chamber pacemaker is doing. So let me just stop that and kind of like go over this, what this whole thing is all about. So any pacemaker is going to, let me just add a layer so I can write on it. Any pacemaker has to be powered by battery. So this thing right here, this is the battery, and then you have a way of storing the energy, and these are capacitors. But you have two chambers: the atrial chamber, which is on the top, and the ventricular chamber, which is on the bottom. So here's the atrial channel and the ventricular channel. Now each chamber is capable of sending out a spike, a pulse, a very brief flow of electrical current where the capacitor discharges over the circuit. And so there's a switch that closes and opens very quickly. Normally, we see like 0.5 milliseconds is like the normal pulse width for a pacing spike. And if you look at a pacing spike on an oscilloscope, it actually has a leading edge voltage and then a trailing edge voltage, and then it cuts off. And this is like half a millisecond from here to here. And this is just a capacitive discharge over resistance. You electrical engineers out there who then went on to medicine, you'll understand what I'm talking about. So this thing here is the switch that closes and the electrical energy flows, and this atrial signal winds up here pacing usually we stick the lead in the right atrial appendage. And then the ventricular has the same capacitor, the same switch that turns it on and off for just a half of a millisecond, and then you can deliver that energy to the right ventricular apex. Each of these circuits, also each of these channels has a sensing circuit. So it's capable of detecting electrical energy at the tip that's acknowledged, and there's a certain sensing threshold, so it has to be above a certain point. And you know, if you're ever playing with temporary pacemakers in the CCU, you can change the sensitivity from like 20 millivolts down to like a half of a millivolt. And the number represents the size of the signal that is acknowledged as being an intrinsic signal. So if you have if the sensitivity is set for 3 millivolts, any signal 3 millivolts or above will be detected and will be acknowledged as an intrinsic beat. Anything less than that will be ignored. So that allows you to kind of like ignore noise and things like that, T waves and so forth. So, but each channel has a sensing circuit. So now let's sort of like take this one step at a time. In the what you have to realize is that, oops, let me just move this layer over here. Okay, so what you have to realize is that each channel has its own clock. Good morning, Matilda and Kaiman. Thanks for joining. Tuning in from the telemetry room. Really? Wow. At Barnabas? How cool is that? Thanks, guys. So, okay. So now, each channel has its own clock. Okay? And this gets kind of hairy. It's really kind of complicated. But each channel has its own clock. In the atrial channel, there's a clock that's known as the AV delay. Oh wait, sorry. Hold on. Whoop. Let me correct myself here. There is, yes. Wait, hold on. There is. Let me just step through this. Yeah, This is the AV delay. So the AV delay is a clock that's usually set for 150 milliseconds, 180 milliseconds, 120, 200, and thereabouts. And so what happens is, as soon as an atrial signal is released, as soon as the pacemaker paces in the atrium, this AV delay timer starts. And during the AV delay, and as you can see, frame by frame, you have the electrical signal now is spreading across the atrium as it forms a P wave, okay? And the atrial channel clock, the AV delay, is running. And it's running, say, let's say 200 milliseconds or so. If it senses a ventricular event during that AV delay, then ventricular output will be inhibited because the patient has an intrinsic QRS complex. So if something is sensed during the AV delay, the ventricular output is inhibited and a second timer starts. The VA interval, or VA escape timer, or the atrial escape interval. Now, so it's getting hairy, right? So now what I've shown is that the AV delay timer expires, and in that case, the ventricular chamber then sends out a spike. So in the case of AV pacing, it would send out a spike, and let me march this out again. See, now the spike has stimulated the ventricular apex in this case, which I wouldn't do, but so now that is spreading and you get a pace QRS complex, but a second clock starts, and that's this one here. And this is known as the atrial escape interval, or VA timer. And what does the VA timer do? It's looking for an intrinsic atrial event. It's waiting to see if a P wave occurs, and when that clock runs out, then it says, all right, there's no atrial event, so now I'm going to pace in the atrium. So that's where the confusion comes in, because people don't realize there's a second clock. Now, how long is the atrial escape interval set for? Well, that's the thing. What you have to think about is the lower rate limit of the pacemaker, which may be 60 beats per minute, minus the AV delay, which if it's 200 milliseconds, then the atrial escape interval is 800. Emory Healthcare, wow, at Atlanta, cool. The telemetry room at Emory, how neat is that? You know, I used to live in Chattanooga, Tennessee. I worked with the Chattanooga Heart Institute, and I used to go to Atlanta, and Emory is a beautiful place, I must say. I love it there. So, so welcome. Thanks for tuning in. So this atrial escape interval is basically a calculated number. The engineers figured out that if you take the lower rate limit and minus the AV delay, that's what your atrial escape interval is. And so when I play this thing, you realize how it's sort of like, oops, wait, this is, let me just reset this thing to the same duration as the video. So now that should loop, okay. And so what's happening now is you have this AV delay timer that as soon as the atrial event occurs, whether it's a paced or a sensed atrial event, the AV delay timer starts, and then it looks for a ventricular event, and if it sees a ventricular event, it stops the atrial escape interval timer and resets the atrial. So you can see how complicated this is. It's crazy, but you can get a sense of whether things are working right or not if you just take out a pair of calipers. So let's grab this here, and we'll grab a pair of calipers and try to figure out what the heck is happening. So now, to figure out what your lower rate limit is programmed for, you have to try to find a set of an A spike and a V spike together. I mean, so it's a little bit difficult, but if we grab our calipers, and now down here we can see that your AV pacing, here's an A spike and here's a V spike, and there's an A spike and here's a V spike. So let's resize our calipers and take it from A to A or from V to V. It doesn't matter, they should be the same. And when we do that, here's from A to A, and you bring it down to the grid, you can measure 300, 150, 175. So it's about 70. So it seems to be operating at 70 beats per minute. That's how you can figure out the lower rate limit. You can figure out the AV delay simply by looking at the distance between these two spikes. It looks like it's less than one large box. I'm going to have to, well, you know what we can do is zoom in a little bit. Ooh, how about that? Zoom in. Ooh, see, because I did this in high resolution. Okay, so that makes it a little bit easier. Is that good? All right. So now let's bring our calipers down. We can measure the interval from one spike to the next. And yeah, it's sort of there. You're gonna have to be a little bit more careful about it because it's so small on the page. But if you bring it up, you can see it looks like it's probably 180 milliseconds, maybe 175. It's less, obviously less than 200. So the atrial escape interval would therefore be, hold on a second. The atrial escape interval would be from the ventricular spike to the next atrial spike. So from here to here is the atrial escape interval. Okay? So if it sees a P wave anytime within here, it resets the clock, inhibits atrial output, and that's what happens when the patient has an intrinsic beat. Okay, so now let's see what's actually happening in the beginning of this strip, because there's some intrinsic beats here. So here's a P wave and a QRS, and there's no spikes here. So you have sinus rhythm, and it's going 300, 150, 175. So look at that, it's about 75. So we told you the pacemaker was set for 70, right? So here what you have is basically sinus rhythm with a rate of 75 beats per minute, and that's why you don't see any pacing, because the patient's intrinsic rate is faster than the programmed heart rate, the programmed lower rate limit. Remember, we measured the lower rate limit going from A spike to A spike or V spike to V spike. But you can only do that when you're AV pacing, because if there's an intrinsic P wave, it shortens the interval from one ventricular event to the other. Then now we're getting very complicated, and we've already spent 23 minutes. I hope you guys are enjoying this. Give me some positive feedback here, or are you just like, you can always go back and watch it again, right? All right, so anyway, interesting is that we have, this is lead 2, and we have a double bump, so we have P mitrale. That might explain why he has paroxysmal atrial fibrillation. You see that double bump? And it's more than 40 milliseconds apart. So when does it start pacing? What actually happened here? I pointed this out already, is that you had this beat, which is early. It's a PAC. Well, what do PACs do? They get into the sinus node and often will reset the sinus node. But if somebody has sinus node dysfunction, it may suppress the sinus node, and you'll get post-tachycardia pauses. You'll even get a pause after a PAC. And that's exactly what happened here. Oops, sorry. So that's exactly what happened here, is that you had the PAC, and then following that, there's no P wave. Okay, so let's take out our atrial escape interval. So we'll grab our calipers again. Sorry, where'd they go? All right, it must be lost in the sauce here, because remember I moved things over. Where are they? Hello, there they are. Okay, sorry about that. So let me grab these calipers and make them bigger and measure the atrial escape interval. And I mentioned that's from the ventricular spike to the atrial spike. All right, so that's our atrial escape interval right there. It would be 70 beats per minute minus that 180 milliseconds. It doesn't matter, you don't need to measure it, but what we're going to do is bring this down now and figure out what happened down below. Because here's your atrial spike. You see, when you see an atrial spike, then you know the atrial escape interval finished. That second clock in the ventricular channel ran out of time, the hourglass is empty, and zapparino, you pace in the atrium. Okay? This is what people don't get. All right? So if you measure back from your atrial escape interval, you see, look at that. It landed on the QRS. So this sensed QRS, okay, sort of like interrupted the AV delay, started the atrial escape interval. And that VA clock, so from ventricular to atrium, that's why they call it a VA clock, expired, and now it paced in the atrium. And you have a P wave here, that's a paced P wave. But here's the thing, why is there a ventricular spike following that when there's a perfectly good QRS complex? Does anybody know what this beat is, what it represents? Because after all, it doesn't look like an intrinsically conducted beat. And here are the intrinsically conducted beats. Right here. No. So here's an intrinsically conducted beat, the one that I'm pointing to, but this beat obviously looks different. Okay? That's because there's a ventricular pacing spike in front of it. You can see it right there. So what happened? Does anybody know? Fusion beat. Jamshid Bahir says fusion beat, and he's absolutely right. That's what it is. Because what happened is the pacing sensing circuit in the ventricle didn't see the QRS. It doesn't see the beginning of the QRS. It only sees the QRS when the electrical depolarization reaches the tip of the pacing lead. Then the pacemaker knows that there's a QRS there. But until that point, the conduction system can become activated and the pacemaker doesn't know. So it paces in the ventricle because the AV delay timer ran out. And so now you have fusion of this interval. It's fused, and then all these beats are fused, and you're AV pacing until the end of the strip. So is fusion good? It's not good because that QRS would have occurred anyway. Now the pacemaker doesn't know that, but you do. You're the doctor. When you see an EKG that looks like this, you're the cardiologist, or you're the ECG reader, you have to go to the EP doc, or you have to go to the cardiologist and say, hey, there's a lot of fusion in the ventricle. You might want to consider extending your AV delay to allow normal conduction to occur. For two reasons. First, if you pace in the RV apex, you might disturb the sequence of conduction, and that's not good, although it looks like most of the QRS is coming from the conduction system. So it's not going to really disturb that sequence of activation all that much. But what's more important is wasting energy, because that battery is being used to pace the ventricle when it doesn't need to. So reprogramming the AV delay a little bit longer is a good thing to do to allow for normal conduction to occur. And that would be the lesson from this cardiogram, is when you see something like this, something like fusion, where the QRS obviously looks like it would have gotten through anyway, by extending the AV delay from 180 or 160 to 200, you could get that pacemaker to last significantly longer. But in fact, this is actually normal function of the pacemaker system, and you don't have to worry about it. The only thing is recognizing the fact that it started to pace in the atrium. Now, why is it, my one last thing, this is a great discussion, and it kind of gives you guys an idea of the world that I live in, and gives you a little bit more insight into how to actually measure pacemaker intervals and figure out what's actually happening. But here's the $64,000 question. Here's the bonus question. Here's the Steve Jobs used to say during the Mac World, and he'd show all these like fancy things, and you'd think, wow, this is fantastic. I'm so excited about these new products. And it looked like he was done, and he would say, oh, but there's one more thing. And then he would come out with like something really cool, like, oh my God. And then, so I've got my Steve Jobs moment. I've got one more thing. Most pacemakers will have separate sensed AV delay and a paced AV delay. They're programmed separately. They're two different numbers. So your sensed AV delay may be 180 milliseconds, your paced AV delay may be 200. But why would you want different numbers? Why do you need different numbers? And the reason is this. If I draw my little John Nagy heart, anybody who grew up in New York in the 60s and 70s remembers John Nagy. He was a guy on public television, and he was an artist, and he had art classes on public television. And he would take a piece of charcoal and a piece of paper, and he'd say, okay, put one line here and put there and put a little swirl down there, and suddenly it would look like, you know, a tree by a lake and with a mountain in the background. It was like amazing. So this is my John Nagy heart, in homage to the good John Nagy, who's long gone. Anyway, so you have your AV node and your His-Purkinje system and everything. So where do we put these pacing leads anyway? Most of the time, okay, the atrial pacing lead is tucked away in the right atrial appendage. As you know, the right atrial appendage is anterior to the superior vena cava, and it's sort of an outpouching, and it's sort of a convenient place to put an atrial lead. Why? Now, this goes back to the early days when they had to figure out some way of keeping the lead in place. So they had these leads that had a preformed J shape, and the right atrial appendage is sort of this outpouching, right? So they would put a stylet. This was before we had the screw-in active fixation leads with a little corkscrew at the end. And so they had a stylet that would straighten out that lead, and you'd get it into the right atrium, and then you'd pull the stylet out, and the preformed J shape would basically grab a hold of that atrial appendage, and then you'd put a little bit of tension on it, and then sew the lead in place. And that was the best we had to anchor the lead, because it was basically, they were just like little grappling hooks. There was nothing actively holding on to the myocardium. Now we have these active fixation screw-in coils and corkscrews, and so you can put the atrial lead anywhere now. But that's why, sort of conventionally, we stick it in the appendage, because it's, you know, it's kind of out of the way. But here's the thing. In a sensed beat, a sinus beat, what happens is that here's your sinus node over here someplace, let's just say. Now, remember, the pacemaker doesn't see the P wave. It only sees the electrical signal when that signal propagates and reaches the lead. So, if you have a sinus beat, all right, it arises from the sinus node and spreads sort of like circumferentially around to the rest of and eventually it reaches that atrial appendage, and that sinus P wave is now acknowledged by the device, and it starts the AV delay timer, right? But by the time the pacemaker sees the P wave, it's already reached the AV node and is beginning to conduct, and it's well on its way to the ventricles. Okay? So what you want to do to maintain a good timing of the left side is you want to have a shorter AV delay, because you don't want that atrial contraction to occur, and then, oh, when's the ventricular spike going to happen? Any day now. By that time, but if you pace in the ventricle at that point, you've kind of prolonged your AV delay. It's almost like you've given the left ventricle a first-degree AV block, and you don't get effective filling in the ventricle. Sometimes you'll get backward leakage from the mitral valve, and it's just not as effective as when you're pacing AV. When you're AV pacing, what happens is, I'll use a different color now. We'll try dark green. So if you're AV pacing with the paced AV delay, so now the P wave starts in the atrial appendage, and it has to travel much, much further, and it takes a lot longer to reach the AV node and then go down, to the ventricle. So you have a lot longer to wait before you have to pace the ventricle. Get it? So your paced AV delay can be much longer, and it should be physiologic, 180, something like that, 200 milliseconds. It should be longer, but you have to shorten the sensed AV delay in order to accommodate for the fact that you're already using up a small bit of that time to get from the sinus node to the right atrial appendage. You see that? Isn't that cool? That's like something that nobody understands. So your sensed AV delay, and think of SS, sense short. So you want your sensed AV delay to be shorter than your paced AV delay, and virtually every pacemaker lets you program them separately, or they may call it something different like sensed offset or something like that. But that's why if you look at this AV delay here, this PR interval, okay, is probably about 180 milliseconds. So you'd wonder, why didn't it pace here, whereas it did pace here? And the reason is that this sensed beat, okay, was acknowledged a little bit earlier, and this likely started to conduct already by the time the pacemaker saw it. All right, so it kind of, so that your intrinsic conduction has more of a chance to get down to the ventricles in a sense beat, because the sensing, the moment of sensing is a little bit later. So your AV delay probably didn't start until here someplace. Get it? And so it had plenty of time to reach the ventricle and inhibit ventricular output. All right, so you might have to listen to that a couple of times. Comment, why are there biventricular paced beats but no biatrial paced beats? I'm not sure what you mean by that. Biventricular paced beats, I don't know if you're referring to biventricular pacemakers, where you have a right ventricular lead and a left ventricular lead. So they're known as cardiac resynchronization therapy. When people have heart failure and they have a left bundle, the problem is that the left bundle results in dysynchrony of the walls of the left ventricle, where the septum and the lateral wall don't contract at the same time. Here, let me make me bigger. So the walls of the ventricle are contracting out of sync with each other because of the presence of the left bundle branch block. So cardiac resynchronization therapy, basically you snake a pacing lead into the coronary sinus and out one of the coronary venous branches, okay, one of the tributaries of the coronary sinus, so that you can actually stimulate the lateral wall of the left ventricle. And by stimulating the lateral wall of the left ventricle at the same time that you're stimulating the right ventricle, you can accomplish a resynchronization of the left ventricular contraction. So that's why it's called CRT, cardiac resynchronization therapy. And you can sometimes see two separate ventricular spikes very close to each other, because sometimes you can program the RV spike and the LV spike to have an offset of 10 or 20 or 40 milliseconds, just to optimize the timing between the left side and right side. That's why you'll see some ECGs show biventricular pacemaker, spikes, but you only see one atrial spike, so you don't really ever see biatrial paced beats because there's only one atrial lead. So if you guys have any other questions, this is great, Jolly. I'm glad you joined us. I'm glad you found it interesting. This is, again, like I always tell people that electrophysiology is like the rocket science of medicine. It's very technical and complicated, and I knew if I wasn't going to be a doctor, I was going to be an electrical engineer. I'm telling you, when I was a kid, my favorite place to hang out was Radio Shack. I was etching my own printed circuit boards, and I was the only kid in my high school who knew how to solder before we went to shop. I was in, grammar school soldering resistors and transistors. So this stuff is right up my alley. I guess I picked the right career. But these live streams, they're fun for me. I hope they're educational for you guys. I hope you really enjoy it, and we'll try to keep them going. And again, if you want to watch this again, you maybe pick up some additional stuff. There's also a whole discussion on pacemaker troubleshooting in the advanced course on ECGacademy.com if you want to check that out. And otherwise, I'm really happy that we had 19 people watching right now, and a few hundred people watch these things every week. So to confirm, the atrial signal is sensed by the ventricular lead. No, the atrial signal is sensed by the atrial lead, but that starts the AV delay. Hey, Amanda, you finally made it. Okay, I just saw a message from one of my nurse practitioners. Thanks for joining me. So the atrial lead senses atrial events and starts the AV delay timer. Okay, and then the ventricular channel is looking for a QRS during the AV delay to see if it needs to pace in the ventricle, and then after it paces in the ventricle, then during the atrial escape interval, the atrial lead is looking for an atrial event, okay? So don't get that confused. No, I'm not on call next week. I'm on every fourth. My group has shrunk down. A few people retired, and moved out of town. So I'm on call every fourth week. But, family things come up. But I definitely appreciate you guys tuning in. I'll try to get notification out the night before, just to give you a chance to kind of, be available so that you can watch it. Okay, so thanks so much for tuning in. This was really fun. I hope you enjoyed it. Don't forget, go in the description and subscribe to ECG Doc, my channel on YouTube, and check out ECG Academy if you want, more formal course. And can I discuss CAB with isoarrhythmic AV dissociation? Well, I'll see what I can do. CAB with isoarrhythmic. Can you maybe leave a comment and tell me what you mean by CAB? Okay, that's easy enough. Great. Thanks so much for tuning in, and I hope you guys have a terrific day. And I will hopefully see you next week. Bye.